Hi, everyone. Welcome back to a CCRN webinar. We're doing a rapid 30 today. Welcome back. Happy Thursday. Hope everyone's doing so well. Let me just get set up here. So yeah, we've transitioned our webinars. We're talking through some respiratory questions and concepts today. Last week, we talked about some cardiac respiratory and concepts. So I'm super excited to get into a new system today. I'll just quickly reintroduce myself. My name's Rebecca. If it's your first time here, I have been an ICU nurse for almost 7 years. Love critical care concepts. Sorry if you hear the train in the background. Love critical care concepts, love teaching and talking about them. And today we're focused on the CCRN. So CCRN is our critical care registered nurse certification. It's an exam that critical care nurses can take to kind of prove their knowledge base in critical care. It's a really um, strong certification to have. It's a difficult exam, so proving that you can obtain the certification really is something to be proud of. And here at Archer Review, we wanted to help nurses do that. So we've now launched a product to help nurses study and prepare for their CCRN using both on-demand video lectures so that you can be very flexible with them, watch them concept by concept in bite-sized pieces, and also take practice questions within 1,000+ question Q bank. Um, we've got some basics here for the CCRN exam. Feel free to take a look at that if you're interested. I really quickly want to pop out of this presentation and show y'all, oops, let's see, our webpage for it because like I said, this product has now launched. I'm just going to spend just a couple minutes showing you what the website looks like and how you can access all of this content for free for 30 days. Super, super exciting. We're offering it for free for a limited time. That's not going to be forever. So I just want to make sure you all know about it in case you are preparing for your CCRN. So here is the Archer Review nursing site. You can come up and find under courses, CCRN is listed. Click that and it'll get you to this web page. You can click try for free right here. It'll zoom you right down to where you can add the CCRN combo, which is the Q bank and all of the on-demand content to your cart to purchase it, quote unquote. But again, it's free for 30 days. And then eventually we will not have that free option anymore. It'll be $159 for a year of access to the QBank and the on-demand videos. This is what the screen, this is what the website looks like in our on-demand video section. You can see here we've got 11 modules of content, all broken down concept by concept. So if we look at this cardiovascular system here, you can just watch a 13-minute video on anatomy and physiology, or you could, if you really want to learn more about pulmonary artery catheters, we've got a 13-minute video there. Just really bite-sized pieces. Or if you want to knock out the whole cardiac system in one day, you're welcome to do that as well. We've got a couple parts there. And then again, like I said, we end up having a total of 11 modules. And then our Q bank, we've got a really nice dashboard here. This is what it looks like when you haven't used it. But we've got 1,085 questions here. You can customize tests. So if you only want to take cardiac questions, that's what you want to focus on today, then you're able to do that really, really easily here in the dashboard. Okay, let's go ahead and pop back into this and let's get started with some content here. I think everything's showing up okay. Like I said, today we're going to talk about respiratory. Respiratory makes up a large portion of the CCRN exam, with it being about 15% of the exam. So it's a system that we want to feel pretty good about. The format of this lecture or this webinar is going to be taking it question by question, and I'll have you guys respond in the chat, whether you're on Facebook or YouTube or you're here in the Zoom. The Zoom account, just go ahead and drop your answers down for all these questions and we'll talk through each concept. So let's go ahead and get started. We're starting here with a question about ARDS, acute respiratory distress syndrome. So in a patient with acute respiratory distress syndrome or ARDS, which of the following factors contributes most to alveolar collapse? I'll just let y'all read through the answer choices. Sometimes I think it's confusing if I read them all aloud. Okay, we've got a few answers coming in. Give it just a couple more minutes or a couple more seconds, really. Okay, so the answer to this question, we saw a couple different answer choices, so that's always kind of fun. It means we've got some things to learn. So the answer for question one is A. A is the correct answer. A is talking about our decreased surfactant production and alveolar flooding. Now, the order in which that answer choice is presented is a little bit interesting. It really is this alveolar flooding, pulmonary edema that's leading to this decreased surfactant production. And when we have fluid filling alveoli, those those alveoli cannot remain open. They collapse on top of that water molecule. So what's interesting about this question and what makes it a really good CCRN question is it these answer choices can all be part of the ARDS pathophysiology. We can see increased airway resistance and bronchospasm with ARDS. We can see definitely airway obstruction due to mucus accumulation. We can see that. Hyperinflation of alveoli is not really as common with ARDS, but we definitely can see some decreased pulmonary compliance. So all of these are factors of acute respiratory distress syndrome. But what is leading to alveolar collapse? And anytime we see that, we want to think about fluid in the alveoli. That really will quickly lead to alveolar collapse, which is what makes A the correct answer for this question. Like I said, that increased airway resistance, bronchospasm, it can happen in ARDS. It's more common in things like chronic obstructive pulmonary disease or COPD. Hyperinflation is not super typical in ARDS, but that decreased lung compliance can occur due to that alveolar collapse and fluid accumulation. But the hyperinflation itself is not the cause of atelectasis. When we see that term atelectasis, I want you to think about alveolar collapse. That's what atelectasis is. And then again, mucus accumulation can obstruct airways in ARDS, but it's not the primary reason due to atelectasis in ARDS. The pathophysiology for ARDS is non-cardiogenic pulmonary edema. We always have that pulmonary edema component with ARDS. And that's usually caused by an inflammatory response happening elsewhere in the body. And it turns systemic. Our whole body gets kicked into an inflammatory response. And now, what do we think of? What are our two main things that we think of when we think of inflammation? It's increased capillary permeability. Oh my gosh, I almost forgot. And vasodilation. So with that, when we've got that happening on the alveolar level, if we've got increased capillary permeability there, we're going to leak fluid into the alveoli. That alveoli is going to collapse, and that's what's going to lead us to ARDS. We can see the difference here. Capillary membrane cells leak out, capillary membranes leaky, fluid enters the alveoli, collapses at alveoli. We cannot have gas exchange when there's fluid in the alveoli. Okay, great job, everyone. Let's move on to question number two. A 60-year-old patient with acute hypoxemic respiratory failure is receiving mechanical ventilation in volume control assist control mode. The patient's arterial blood gas results are as follows. pH is 7.22, PaCO2 is 55, PaO2 is 50, and bicarb or HCO3 is 24. Which of the following interventions is most appropriate to improve the patient's oxygenation? And again, I'll just let y'all read those answer choices yourself. Seeing a couple answers come in. Everything looks really good. Give it just a couple more seconds. See if we can get some more answers. All right, couple different answers. but overall looking pretty good. I see him trickling in. Okay, let's go ahead and answer this one. So before I reveal what the answer is, this is a loaded question. We've got a lot of things to think about when we read a question like this. We're seeing that we have a patient in hypoxemic respiratory failure, which means they have a low oxygen saturation or a low oxygen level on their blood gas. They're already intubated. They're receiving mechanical ventilation and it's in the mode of ACVC, so a very high control setting. So the patient's under a lot of respiratory support when they're on that mode on the ventilator. Now their ABG still doesn't look good. Can somebody drop in the chat what this ABG is telling, the interpretation of this ABG? Is this a compensated metabolic acidosis? Is this a partially compensated respiratory alkalosis? What are we looking at here? Can somebody tell me that? It's a little off subject from the question, but we might as well take the practice. Okay, perfect. I see an answer from Zoom. That looks really good. I don't think anybody else can see it, so that's good. Okay, I'm seeing some. Perfect. So this is an uncompensated respiratory acidosis. Great job, Jennifer. Great job. A couple people on Facebook. Perfect. So we notice that whenever I look at an ABG in a question, I'm going to go ahead and interpret it. What am I seeing? Now, to interpret the acid-base balance for an ABG, we're just looking at pH, carbon dioxide, and our bicarb level. We're not looking at our oxygen level to interpret that. But this question is about the oxygen. So we want to interpret these ABGs, notice them, paint a picture for our patient from the question, but then hone in on what the question is asking. So this is saying which of the following interventions is most appropriate to improve the patient's oxygenation. Great job, everyone. Everyone got this acid-base balance correct. I'm seeing in the responses. So awesome. So the answer for this one is going to be C. We're going to increase our positive end expiratory pressure, or our PEEP, which a lot of people said. The other answer that is probably the most tempting would be B, to increase our tidal volume to get this patient, theoretically you're thinking, let's give them more air. That way they can get some more oxygen. Now with C, when we're talking about PEEP, or when we're talking about ventilator settings in general, I'm thinking of two main settings that help contribute to my oxygenation. The obvious one is how much oxygen are we giving our patient? So on a ventilator, that's going to be in the form of an FiO2. That's the first thing we can adjust, but we don't want to go crazy with FiO2 without also adjusting PEEP, because oxygen toxicity and things like that are a problem. So we want to increase both of these two oxygenation settings kind of in unison, unless the patient's on certain protocols. Now, increasing our PEEP, positive end expiratory pressure, how does that help with oxygenation? It's obviously not giving more inhaled oxygen content like FiO2 is. What it's doing is it's keeping our alveoli open for longer. And with that previous ARDS question, we talked about how our alveoli are not participating in gas exchange when they're closed. They're only participating in gas exchange when the alveoli is open. If we can keep some pressure in the lungs after the patient exhales, so after that end expiratory pressure, if we can keep some pressure in there, keep some alveoli open, we're going to increase the amount of time that the alveoli can participate in gas exchange and therefore increase our patient's oxygenation. Now, going through all the answers, we know that A was incorrect, lowering the respiratory rate. If anything, we would increase our respiratory rate to help adjust this respiratory acidosis, right? But even then, even if the question, or even if the answer choice said increase the respiratory rate, that would still not be a correct answer to this question, because that would help improve our patient's acid-base balance, our patient's respiratory acidosis, but it would not improve our patient's oxygenation. Tidal volume, we really don't adjust. This is a weight-based number. It's usually 6 to 8 mLs per kilogram. We don't want to just give the patient more air every breath to help fix this oxygenation problem, because we've got risks of alveolar overdistension and barotrauma. So that's going to be a later idea. We're usually keeping our tidal volume pretty constant. And D, a bronchodilator, it could be helpful, but it's not going to do exactly what we need for this patient who's already on mechanical ventilation. Okay, and I've got a little bit of respiratory failure pathophysiology here. Both, we've got two types. They're both hypoxemic. A main problem with our respiratory failure is alveolar hypoventilation. If we can add some PEEP in, we can keep our alveoli inflated for longer. Ways that we support these patients is oxygenation and ventilation. Especially in the presence of a shunt being when we have that alveolar collapse, blood flow is still going to those alveoli that are not participating in gas exchange, and therefore we're going to have blood returning to the left side of the heart that is hypoxemic. So we're going to need to open some alveoli to combat that. Ventilator settings, here they are listed, PEEP and our oxygen concentration. These two settings are what we care about for oxygenation. Respiratory rate is what we would adjust to adjust our CO2. Okay, awesome job, everyone. That was really, really good. Question three, a 65-year-old patient with chronic obstructive pulmonary disease or COPD presents to the emergency department with severe dyspnea, use of accessory muscles, and increasing fatigue. Despite receiving nebulized bronchodilators and corticosteroids, the patient's respiratory effort is declining and they appear lethargic. What is the next best step in management? Okay, starting to see some answers come in. I'll give it just a couple more seconds. Great job, everyone. Okay, perfect. We seem to feel pretty confident about this. I'm only seeing a couple different answers out there. So yes, our answer here, most of you got it correct, is B. We're going to initiate non-invasive positive pressure ventilation. Now, we luckily were given a patient who has COPD. We know that they are going to have these obstructive airways that need positive pressure to open them. When they come in and they're coming into the emergency department, that means we know that they haven't been here for super, super long. We didn't receive any information about what oxygen status they're on. So I'm going to assume that they're either just on or they're on room air, which hopefully if somebody comes in with those symptoms, we're putting them on some amount of oxygen pretty quickly. The problem is we need to open up some airways, open up alveoli, open up airways, and we're going to need pressure to do that. Just applying oxygen is not going to fix the respiratory distress, borderline respiratory failure that's happening in this scenario. We need pressure. So that is why B is the answer. So congratulations. I think most everyone got that correct. High flow nasal cannula is great oxygen support, but it is not going to work when we have that obstructed airway problem and bronchospasm. C is incorrect. That's just a distracting question. We don't really give that medication. And corticosteroids, they take way too long. If we've got a patient who is in active distress, we've even tried steroids and it doesn't seem to be working. But even then, we are not going to rely on corticosteroids to fix an acute problem. Because that is just those types of medications are more for consistent treatment over the course of that patient's stay. COPD, we've got two main types, emphysema, which is an alveolar problem, collapsed alveoli, chronic bronchitis, which is an airway bronchial problem. COPD exacerbation looks like dyspnea, sputum volume, and purulence in that sputum. We treat it with lots of different things, but again, these steroids take 6 to 8 hours to take effect. We want to provide some ventilation support. Okay, Question four, let's keep moving. A 72-year-old male patient with a history of chronic anemia is admitted to the ICU after experiencing acute hypoxemia and respiratory distress during a red blood cell transfusion. He is rapidly intubated and placed on mechanical ventilation. A chest x-ray reveals bilateral pulmonary infiltrates without signs of cardiomegaly. Which of the following is the most likely cause of his respiratory failure? Kind of a long question there. Okay, seeing a few different answer choices come in. Let's keep going. We'll give us just a couple more seconds. I'm seeing answers all over the place. I'll give you a hint. I'm not sure before I say this. Okay, I've only seen the answer a couple times. So this will be a good one to talk through. And this is a difficult question. Okay, let's go ahead and talk about it. So the correct answer for this question is C, a transfusion-related acute lung injury. I got a lot of answers for A, ARDS, as well as B, TACO, or circulatory overload. But there were a couple things, a couple symptoms in this description that told us kind of ruled some of these other options out. Now, I will say that what makes this question a little bit difficult is I consider TRALI, transfusion-related acute lung injury, to be a form of ARDS. Now, still, the most correct answer, knowing that this patient received a red blood cell transfusion, the most correct answer is going to be this C, this transfusion-related acute lung injury. But it is hard because it acts very similarly to ARDS. So if you said ARDS, I totally see where you're coming from. Know that this is a form of that. So what we saw that differentiated TRALI from TACO, the circulatory overload that we can get from a transfusion reaction, is we don't have signs of cardiomegaly. I mean, we didn't see them talking about anything like jugular venous distension, elevated BNP. These are the things that we're likely going to see with a patient who has generalized fluid overload. That's when you see that circulatory overload, we're thinking fluid overload. And we weren't seeing that. We were seeing those bilateral pulmonary infiltrates, meaning we're getting flash pulmonary edema. This patient is having an immune response to that unit of blood. Their lungs kick into that inflammatory system, and we get a flash ARDS in the form of TRALI, that acute lung injury. So yes, TRALI is non-cardiogenic pulmonary edema. Um, so yes, TRALI is technically a form of ARDS, makes it a little bit difficult. Most specific answer would be TRALI, and TACO would have slightly different symptoms from what we're seeing here. Now, could we have bilateral pulmonary infiltrates with TACO as well? Yes, but it's more likely TRALI. Okay. And we've got that kind of listed here. Sudden shortness of breath from the pulmonary edema, tachypnea. In high-risk patients, if we know that a patient is susceptible to this, maybe they've got lots of antibodies in their blood, we're going to give leukocyte-reduced blood so that the patient's antibodies will not fight those donor white blood, or I'm sorry, the donor white blood cells will not fight the patient and cause an inflammatory response. Okay, let's move on to the next one. A critically ill patient is found to have a large pleural effusion on chest x-ray. Which of the following best describes where the fluid has accumulated? Okay, seeing some answers come in. This is a good anatomy question. I'll wait just a couple more seconds. Couple different answers showing up. That's all good. Okay. Okay, so the answer for this is C. We've got lots of different anatomical spaces in this question. Between the two layers of the pleura is not super descript, meaning you'd kind of have to feel comfortable at what those two layers of the pleura are. Can somebody type in our two pleura layers? I see visceral. Good job, Bina. And then, so we've got the visceral pleura. What is the other pleura? And parietal. Good job, Jennifer. I see some on Facebook as well. Great job. So we've got our visceral pleura. When we hear the word visceral, that's always talking about an organ. So the visceral pleura is the lining um, on the lung tissue. I've got a picture here. And then our parietal pleura is the inner lining of our chest wall. In a normal situation, when everything's acting normally, we have an airtight space between the visceral and parietal pleura. They are right next to each other. There's just a small amount of lubricating fluid in between them so that there's no friction with inhalation and exhalation. But for the most part, they're airtight. And we know that because the intrapleural pressure is typically negative. There's almost like a suction effect there. So that is where, when we have a pleural effusion, we're seeing more than just that lubricating fluid develop in that area. It is a true pocket of fluid, either from inflammation or hypervolemia. There's a few different causes for pleural effusion. Um, Yes, and the rest are just incorrect. When we've got within the lung parenchyma, that is not the pleural space, subcutaneous space on either side of the trachea. That's normally where we see subcutaneous emphysema, so air accumulation, and we get that kind of Rice Krispie skin. That's where we would see that. And then between the muscle and subcutaneous tissue of the chest wall is beyond this area of the pleural space. Now we're talking truly in the chest wall. Okie dokie. This is our last question. We'll finish quickly with this one. 50-year-old patient arrives to the emergency department in severe respiratory distress. On assessment, the nurse notes a high-pitched inspiratory sound when the patient breathes in, suggesting obstruction at which airway level? Another sort of basic assessment question. Do we feel good about these sounds? Okay, we're seeing answers all over the place. Again, always kind of fun. That means we've got lots to learn. It wouldn't be helpful if they answer if we just knew everything to these answers. So that's always good to see. But most people are getting this correct. Okay, gonna go ahead and close out here. The answer to this question is, oh, I almost said the wrong one, is B. High-pitched inspiratory sound is talking about stridor. When we have stridor, that is when we're hearing an upper airway obstruction, whereas when we have wheezing, we're more likely to be hearing a lower airway obstruction. That one's don't have too much to elaborate on that. Um, Okay, that is it. I want to drop our QR code for our next CCRN webinar. It's going to be on March 4th, so just coming right around the corner on the other side of the weekend. Tuesday, March 4th, 12 p.m. Central Standard Time. Here's a QR code to sign up. Or if you go to our site, it's right there in the top. Of the CCRN website. There's a little section for free webinars, and you can sign up for any of the free webinars that we have scheduled. You can sign up for them right there. Okay, any other questions or anything that I can answer, especially about the site? Definitely go and check it out. See if you want to try the on-demand lectures. All the practice questions, over 1,000 practice questions, all with rationales. Really a great question bank. I'll just leave this up here for anybody who needs it. What time in the Philippines? I don't know. I'm sorry. I I don't know. Okay, everyone, I'm going to go ahead and let you go. We will see you on Tuesday to talk about, I didn't even tell you what we're talking about. We're going to talk about hematology in that one. So again, go through some questions, talk about some concepts, and focus on hematology.